Good day and welcome to this continuing series on improving your reimbursement from the Practice Protection Committee. I'm Pat Bailey, Medical Director for Advocacy in the DC office, and I'm again very pleased to be joined by Mark Savarise and Charlie Mabry, who will be taking us through part 2 of this Beyond Coding section of their Improving Reimbursement Analysis.
Well, thank you, Pat, and it's good to be here tonight. So just to review very quickly, in our first PowerPoint, it was work smarter and then to work harder. The work smarter part deals with maximizing the RVWs or RVUs bill for work, improve your average conversion factor by negotiating with your various commercial carriers, take advantage of any facility-based reimbursement by moving the location that you practice or do procedures, and then understanding commercial insurance as well as contracts and various things there. And then maximizing the value of your APCs, and not only that, but take advantage of your non-RVU based payment to avoid penalties. So this is kind of the overview of how we're going to talk about tonight, what we're going to talk about tonight.
So the biggest portion of this talk relates to commercial insurance. And we're going to go into a little bit of detail about what the practicing surgeon should know about their commercial insurance. There are important things for all surgeons to understand about commercial insurance. Unfortunately, most of us did not learn this in school because we didn't take that business class. It's important to understand the insurance contracting process. Everybody has to contract for insurance. It's important to understand how you pay or don't get paid for your services. And it's important to understand the appeals process. And we'll break this down and go into a little more detail here. Let's start by talking about insurance contracts. A contract with an insurance company is a negotiated agreement between your practice and their company that provides you a form of payment for the work that you do on the patients who are in their network. Now, there's a lot of terms that get thrown around, and this is where it gets tricky. What most surgeons concentrate on appropriately is the fee schedule. That is, how much are you going to make for each of the procedures that you do? That's really only a small part of your insurance contract. And depending on how much leverage you have, you may not be able to negotiate the fee schedule at all. But there's a whole bunch more to the insurance contract that you need to understand. It's important to understand preferred provider networks. And 20 years ago, this didn't exist much. And now this is very much the way things are done everywhere. And in that insurance companies direct their patients to certain providers of services, and where you are in their network and what tier you might be in a network is important to know. I got some help from some surgeons who had been in practice long time when I asked them about insurance companies and was told about some dirty insurance company tricks. There are insurance companies that run what are called silent preferred provider organizations. You don't know if you're in their organization or where you are in their organization. Most insurance companies have certain exclusions to coverage, which is usually a 100 or 200 page PDF located on their website someplace that can trip you up. And then insurance companies are notorious for delaying payment for valid claims. And then just one other point to make about this is this concept of out-of-network status. If an insurance company isn't providing you with a contract that is to your benefit, oftentimes you are better off not being in network with that insurance company. But knowing that you're providing out-of-network services to someone is really important, that you don't do that unless you know that you're doing that. It's important to know that up front before you perform the service.
And it's important to tell the patient so that they understand it also. Most patients that I'm familiar with value the surgeon more than they value their insurance company. And if they understand that they're doing something out of network, they're more than willing to have surgery by someone that they trust and know, even though it may cost more, because of the fact that that they know you and they trust your skill. You know, surgery is very important to whoever's getting it, and the out of network status is interesting, but not necessarily vital to the patient that wants surgery or needs surgery done by a good surgeon.
And oftentimes, a good surgeon can still provide that service at a rate that's not really significantly higher than what a patient's in-network cost could be. I was involved in something where we took our entire ambulatory surgery center out of network with the primary provider of services in the area because we couldn't negotiate a good contract. And we stayed that way for about 2 years until we were able to renegotiate the contract with the big insurance company.
One thing to add on this is what I call the slow no, and that's hard to detect unless you watch your collections by insurance company, and for your billers, the way that you want to look at that is called an aged accounts receivable report, in which they take the different claims and age them by 30-day buckets, and then do that across this way, and then down the sheet in the Excel spreadsheet, you want to see it by insurance company. So if someone's paying you very slowly, they're delaying payment, you'll see their dollars move from 30 days to 60 days to 90 days with no change in them, and all of a sudden they'll pay at 120 days. So that's how you detect that. It's an aged accounts receivable report by insurance company and by 30-day increments.
Insurers have a lot of ways to underpay, and delayed payment that Dr. Mabry was just talking about is probably the most common and most accepted among insurance companies. If you understand anything about the time value of money, and insurance companies are doing this to hundreds and thousands of medical providers around the country, they are keeping money for months at a time. They're making a very big profit off of that. So there's a very good incentive for doing that. There's the outright denial of service, where you do something that you think should be covered and they simply say no. Now, there are insurance companies who will do this routinely, even though it's reasonable to be covered, because the process of appealing denials takes time. And with that time value of money, this insurance company might still pay you and reverse the denial, but if they keep the money for an additional 90 days while you're appealing, they're making money on it. Another common phenomenon is downcoding, where, particularly for a complex operation, you list multiple codes for a procedure, and the insurance company only pays you the first code that you list, or the first 2 codes that you list. It doesn't have to be a super complex cancer operation either. We see this in ventral hernia repair with component separation, for example, where the insurance company will deny about 2/3 of the claim. Insurance companies have gone to applying Medicare sequestration rules to their insurance payment, even though there's no reason to do that. Medicare sequestration rules have cut back a percentage of payment, and because insurance companies follow Medicare rates at a percentage, they just take that right off the top. And then we talked a little bit about being out of network. If you're out of network for a service, you don't have to accept the in-network contracted rate, but you might find insurance companies are paying you at that rate.
Well, there's some other things to help you when working and getting payment for insurance contracts. On the fee schedule, one of the other helpful things is for each insurer or a contract plan within a big insurer, keep a list by CPT code of the payment or allowed charges. As Mark was alluding to, when you sign a contract with an insurance company, they usually have a list of 20 codes of what they pay, but that's of course not very helpful for a general surgeon who often codes in the hundreds of CPT codes. So you can make your own list or keep your own list. It can be nothing more complex than a legal pad that the coder biller keeps by his or her station and writes down for a given insurance company the allowable for each CPT code. Over time, that allows you to build a very important resource to tell you what each insurance company pays for each individual CPT code that you use. And then that allows you to tell, once again, when the time comes to sign your contract for a company, whether or not you want to sign with them. Now, one of the other real big questions is, are my fees too high or too low? And we'll go to the next slide in just a second, but that's where the gross collection percentage report is very helpful. And then the net collection percentage report is a way to pick up or detect these dirty insurance company tricks, where there's a silent PPO or exclusion of coverage or slow no. So these two ways, the gross collection percentage and the net collection percentage, those two tricks or techniques are very helpful to allow you to understand when those are occurring. So let's go and show an example of that. So this is a hypothetical. Dr. Casey, Dr. Kildare, and Dr. Stanley, in almost any practice management software will be able to produce this type of report, where you line up the charges, you line up the adjusted charge, that is the charge after the contractual allowance is taken into account, and then payments. Now the gross collection percentage is the payments divided by the total charge. The net collection is the payments divided by the adjusted charge. And typically for a gross collection percentage, you'd see something in the 30 or 40% range. The net collection, if your office is operating efficiently, should be in the 80 to 90% range. You should collect and expect to collect around 80 to 90% of what your charges are if it's been adjusted for the contractual allowance. So the gross collection percentage tells you the quality of the payer source. That is, the higher the gross collection percentage, the better that insurance company pays you for the work that you're creating. And the net collection percentage tells you the efficiency of your office insurance processing and collection activity. And so those are two easy and simple techniques to use from just one report. Now, if you take that concept and by insurance company. Now, first report was by doctor. Now, this is by insurance company. And you can see on the left-hand side, there's Medicare and some other companies. The way to think about this is, first, sort this report by the most frequent company. So we have this sorted in descending order, and that gives you, for most practices, in the top part of this, the top 4 or 5 companies, the majority of your claims are going to be in these few companies, and you can focus on those. And once again, you have the quantity, the contractual allowance, payment allowance, etc. This tells you your percent of charges, and then your gross collection and net collection percentage. This also allows you a quick look at how your companies are paying you, and something looks too low, like this 45% on net collection for Medicaid, then you have to ask questions, well, why is that so low? Or this other one, Medicaid guaranteed respondents, is also only 5%. So these things tell you very quickly which companies are valuable and pay appropriately, and which companies are either slow knowing you, or not paying you, or denying your claims. Now, the way to think about this is these are 90-day plus claims, that is, claims that have been submitted, and then you age them for at least 90 days, because it takes about 3 months for the paperwork to go through, the electronic payments to go through, etc. So wait at least 90 days, and then sort this by insurance company using the gross and net collection percentage. It'll be a very helpful report to dive into your own practice and see what's happening and where the money's coming from and who's not paying you.
The other thing that you should also be familiar with is the EOB, or explanation of benefits. Every claim is responded to with an explanation of benefits, and most insurers will bundle their claims onto a single EOB for your practice for a certain amount of time. What an EOB will tell you is things about the timeliness of payment. That is, which claims are getting paid rapidly within 30 to 60 days, which ones are aging more than 90 or 120 days. It also shows what you're paid versus what you're allowed under your contract. And then it has rationales for denials and downcoding. And what we've found is that in most practices, up to a third of claims are not paid accurately and properly. And if you don't dig through the EOB, you may not find out where. particularly paying attention to the denial rationale remarks for individual claims, which are often vague comments that require more work to dig into. It may turn out that you've misunderstood your insurance contract and you're always going to be denied for this, in which case your EOBs will look the same over and over and over again. Or it's also possible that just some reviewer went through and arbitrarily denied this claim and assigned a rationale to it. And when you go and you look at another EOB from the same company, the same claim for another patient gets paid. If that's happening, this is why it's important to audit your EOBs, because you have a rational reason to go back and appeal and get paid for those things.
So Charlie, how often do you review your EOBs? And what process do you use?
We actually review those on a regular basis in our office. Now, I don't personally review them. I over time, I've trained my personnel how to review these. But even for employed surgeons, this is almost like the map to the lost gold of Sierra Madres. And surgeons don't like to think about this, but actually, this is where a lot of value was created by you, the surgeon, but they're gypping you or not paying you on the back end. And so this is money in the bank that you need to collect or try to get collected. So if you're employed, over time, as they review your contract, if you show an interest in this and you can show administration that, look, I went in and looked through my EOBs and look at the extra money I've through my incentive, my uh, uh, diligence have recovered, that then helps you in your contract negotiation as an employee. On the other hand, if you're in private practice, this truly is sometimes the lifeblood of your practice, looking through the EOBs and understanding what is going on. And if you're having unnecessary denials or inappropriate coding on your end, you'll determine that and detect that by looking at the EOBs.
And Pat, having gone from private practice where my office manager went through the EOBs regularly, and I actually saw these things, to being employed by a large institution, I've now gone away from seeing EOBs on a regular basis. They go to some billing organization. However, like most employed RVU-based surgeons, I get monthly reports about how I'm doing. And looking through those monthly reports of the codes you generated for the month, what your charges were, gives you some clues as to where you might not be getting reimbursed properly for things. And so once you look through that, that may point to areas where certain insurers or certain procedures are a problem for your billers. And then you go back and you ask them to dig through those specific EOBs. And even as an employed surgeon, there is value in doing that stuff. It's just one layer separated from you.
Well, one important thing to remember: many employed surgeons in that practice model, the RVU that is credited to the surgeon is only credited once that RVU is paid. So once again, you may not be in practice if you're an employed surgeon, but your RVWs count towards your bonus or your productivity. And if you're getting denials inappropriately, then you've created the RVW, but you're not getting credit for it because it's inappropriately denied. So this is important to every surgeon out there. It's dull, it's drab. We get it. We know it's not fun, but I'm telling you, this is a great way to look at it, along with the net collection and the gross collection percentage reports.
We're changing the topic a little bit because we've been talking a lot about insurance. This still applies in some way to your insurance contract, and it deals with unlisted codes. As we explained in our introduction to this, all procedures come with a CPT code. Well, we weren't entirely honest about that, because all established procedures come with a CPT code. And there are a lot of things that surgeons are doing that don't have specific CPT codes because they're still considered too new or experimental to have gone through the process. And some good examples are robotic procedures and some hybrid laparoscopic open or laparoscopic endoscopic procedures that are being done by a lot of new surgeons coming out that don't have existing CPT codes, and therefore they don't have an assigned work RVU value. So these are problematic in two ways. If you are in private practice and you rely on getting reimbursement directly from an insurance company, you have to negotiate payments for these codes separate. If you're on an RVU based contract where you're getting a salary or bonus that's based on your RVUs, if what you're doing doesn't have an assigned RVU, you need to adjust that into your contract as well so that you get credit for these unlisted codes. And this is something that you need to do up front because it's easy to overlook a year or two into your practice and find out that a lot of your work you're not getting paid for.
This would seem to be the perfect opportunity to utilize like the coding hotline and to utilize the resources of the GSCRC.
Well, that's right, Pat. I think these are areas that we as experts will try to help the fellows. One thing you can do for your organization, let's assume that you're employed, you're getting paid by the RVW. Codes that are listed as a C-type code, those are contractor priced, have zero value to RVWs. The unlisted code, anything that has a 999 on it, is also a zero RVW. There's no value assigned to that. So how do you determine, or how do you get the right value for an RVW for an unlisted code or a code that has no value? One of the ways is to crosswalk it to a very similar code. So for instance, if you're doing a robotic uh, organectomy, you can look for the open organectomy and ask your institution to crosswalk that value to the robotic code, perhaps with an upcode for the complexity of the robotic approach. Another way to do it is get a group of codes in a family. For instance, the different lung procedures to resect part of a lung, those will circle around a given RVW value, and you can use a family of codes to then crosswalk that to the unlisted code. So remember, don't give away the value that you created, but you have to be diligent to understand that a code that you charged may have a zero RVW value and a zero price, and therefore make sure that it's coded correctly and then paid correctly.
Two final points to make regarding working smarter. One relates to physician extenders, nurse practitioners, and physician's assistants that you're using. And while a PA or an NP can get paid for some things, they can't get paid for everything. And the surgeon tends to get paid more for the same tasks. So there's some complex rules around this, but the general principle is that as the surgeon, you should be at your most cost efficient tasks. And that's mostly operating, but not entirely. That also involves the evaluation and management of your complex patients who are going to the operating room. And so in a couple of instances, you should consider using your APC very wisely. In the operating room, if your APC can get paid as an assistant at surgery, that's advantageous for both you and your APC. And so using that APC wisely in the operating room is important. When you're doing evaluation and management services, different insurers have different what are known as incident to rules as to how they will pay an APC. Sometimes the APC can get paid the full value of an E&M service, in which case it makes sense for the APCs to be doing all those evaluation management services. Sometimes it requires co-management, and knowing the rules of those things is important. And then it's important to remember that all of your post-operative global management is essentially bundled in. And so for most practices, it makes sense to have your APC doing some of that low value work. Now, again, that's not universally true. So understanding how to get maximum value out of your APC is an important, complicated topic that you should look into.
As Mark says, the incident to and shared or split billing rules are quite complex. In fact, many of us still have trouble trying to get them straight from time to time. So we wouldn't expect the average surgeon to know about those and be expert at it. But as a general rule, if your advanced provider is there in the office with you and you're both seeing patients at the same time, it's perfectly appropriate for you to bill under your NPI number for the work that both of you do. However, if you're in the operating room and your advanced provider is in the office seeing patients, then you cannot bill with the incident to rules. You cannot bill for work that they do while you're in the operating room doing something else. So as long as you're with them and able to supervise them, then you're good to go, I think.
And then one final point is to consider that there are payments out there that are not based on RVUs. The incentives for quality measures are the best example. MIPS through the Centers for Medicare Services, along with other individual incentives that might come through your employer or your insurance network, might be worth taking advantage of. Now, that said, some surgeons have found that the work involved to achieve payment for these quality measures was more than what the quality measure reimbursement turned out to be for them. So your individual results may vary on this, but don't take penalties and don't leave easy money on the table.
Very wise words.
So in summary, we have talked over these last two lectures about how surgeons need to work harder and, more importantly, work smarter to maximize their reimbursement. In the first lecture, we talked about efficiency and working harder. We talked about how you maximize your RVUs and how you look at your conversion factor. And we discussed a few ways that surgeons can address the disparity in physician reimbursement versus facility reimbursement. On this side, we talked a lot about your commercial insurance contracts and briefly about how to use your APCs and how to take advantage of non-RVU based payment. This is in no way comprehensive, and I'm sure that there are a whole lot of other obstacles and opportunities out there for surgeons in the real world.
And I think the only parting thought I would have is to urge the fellows to go to the College of Surgery website under Advocacy and then under Practice Management. There's a whole list of very good articles, very good resources for the fellows out there to use that will explain a lot of this and go over it again in more detail. So don't forget to look at the college website on a frequent basis. Our committee, the Coding Reimbursement Committee, puts out updates almost every month on the latest new codes, the latest new coding tips, etc. So it's a resource that is not only there and valuable, but is updated constantly to help the fellows.
Mark and Charlie, again, I thank you very, very much for sharing this wealth of information, both practical and technical information that will be useful to our fellows as they try to improve their reimbursement under the current environment that we're living in. We hope that you'll continue to join us for our videos from the Practice Protection Committee, and we wish you a good day.